Good afternoon and good morning, depending on where you are. Welcome to NIMHT webinar on Transdisciplinary Collaborative Centers for Health Disparities Research on Chronic Disease Prevention, RFAMD 15014. My name is Xinji Zhang. Here with me, Dr. Michael Sayre, Chief of Office of Research Innovation and Program Coordination, Dr. John Wassman, Program Official at NIMHT, and also NIMHT Scientific Review Officer, Dr. Marilyn Lolly Sharp. Also with us here, our Technical Lead, Edgar Juice. Here is a table of contents of what we are going to talk about today, including objectives of the FOA, application components, budget, NIH peer review, and selected frequent asked questions. Then we will open the floor for questions and answers. First is just a brief description of the NIMHT TCC centers. NIMHT Transdisciplinary Collaborative Centers for Health Disparities Research was established in 2015. The purpose is to comprise regional coalitions of research institutions and consortium partners focused on priority research areas in minority health and health disparities, to develop and disseminate effective interventions that can be implemented in real-world settings, and to disseminate knowledge that is culturally appropriate and that will benefit impacted communities. Previously, we have TCCs on health policy, men's health, social determinants of health, and now we have other initiatives. Again, we established TCC in 2012. Now we have precision medicine on the street and also these chronic disease initiatives. For this funding opportunity, this FOA invites applications to establish specialized TCC for health disparity research focused on chronic disease prevention with an emphasis on developing, implementing, and disseminating community-based multi-level interventions. The objective is to improve chronic disease prevention and promote health equity, to initiate and implement multi-level interventions at individual, family, team, group, community, or higher levels, at least 3 or more levels, to focus on primary and or secondary prevention, use a transdisciplinary, collaborative, and systems approach, and encourage working extensively with community partners. Here are a list of required components and page limits. The overall component page limit is 12 pages. For the administrative core, it's 12 pages. For other consortium core, methodology core, dissemination core, the page limit is 6. And for each intervention project, the page limit is 12 for each project. For the overall component, to initiate and implement multi-level interventions at individual, family, team, group, community, or higher levels to improve chronic disease prevention and promote health equity. In the application, please describe the overall composition, objectives, specific aims, and expected outcomes of the proposed TCC, to identify the health disparity populations to be included in the proposed projects, and describe the chronic disease prevention focus, and also to delineate the geographic regions to be covered, including the HHS regions where the proposed work will occur. For the administrative core, to provide overall project evaluation, ensure that component plans are implemented according to proposed timelines, monitor progress on intervention projects, and ensuring that TCC-supported research is carried out in compliance with applicable federal regulations and policies. So in the application, please describe the TCC's organization and the governance structure. Describe how the administrative core will manage, coordinate, and supervise the entire range of proposed TCC activities, and also include an evaluation plan to monitor progress on proposed TCC activities. In the consulting call, which serves as a focal point for organizing and nurturing productive working relationships with all consulting partners. So in the application, please explain the scientific rationale for including the consulting partners, summarize the strengths of proposed consulting, describe specific opportunities to establish or strengthen associations with other relevant agencies. Also describe strategies and procedures for assessing the effectiveness of partnerships on an ongoing basis and resolving disputes or misunderstandings between partner organizations. In the methodology call, which formulates appropriate theoretical framework, study design, data analysis plan, and assessment of community-based multilevel interventions. So in that application, please describe the roles, responsibilities of the key members, as well as collaboration with regional partners with methodology expertise. Describe a comprehensive needs assessment in the community. Describe the theoretical conceptual model supporting the multilevel chronic disease prevention. Also, please describe the scalability and sustainability of the proposed interventions. For intervention projects, at least 2 projects with different multilevel intervention need to be included. Also, need to describe close collaboration with consulting partners, and multiple chronic disease conditions are encouraged. So in the application, please describe the multilevel approach used in each project. Describe type of prevention, primary or secondary, to be addressed. Also describe what chronic disease condition is being targeted and what potential clinic and other outcomes are anticipated. The dissemination call identifies, develop effective methods, systems, infrastructure, and strategies to disseminate research findings. So in the application, please describe strategies to keep various stakeholders informed on an ongoing basis. Describe strategies to use research findings to inform policy and to promote diffusion, adoption, and sustainability of effective multilevel interventions in relevant communities. To describe plans to ensure protection of study participants and communities from unintended harms. Again, I want to emphasize this TCC FOA has a regional focus. Here, a list of the regions. It's also mentioned in FOA. I also want to mention the funding instrument. This is a U54 mechanism, U54 Specialized Center Cooperative Agreement. The dominant role and primary responsibility resides with the award recipients. However, there's substantial NIH scientific and programmatic involvement. For program officials, will be involved in scientific and programmatic issues. And also we have project scientists, which will more involved in scientific involvement through technical assistance, advice, and coordination. As mentioned in the FOA, the budget allocated is about $5 million. We intend to fund 2 to 3 awards. For each award, it's about $1.5 million direct cost every year. This is a list of key dates. It's also in the FOA. I just want to remind everybody that due date is December 16th, 2015. Now I'm going to hand over to our review officer, Marion. She will go over the review process.
Good afternoon, everyone. This slide has a link to a training for reviewer if you are interested to becoming a reviewer if you are not already. So I'm doing a little bit of advertisement for review. The next slide. So the peer review process. First, the application will be assessed for completeness by the Center for Scientific Review, CSR. The NIMHD program staff will assess the application for responsiveness, and the NIMHD scientific review officer will assemble a panel of experts from the extramural community to peer review the application. At least 3 assigned expert reviewers will assess the overall impact of each application based on established criteria. So the reviewer evaluates each application potential to succeed. And so the 5 criteria that they are looking at for the overall impact is significance, investigators, innovation, approach, and environment. The overall impact criteria take into account the evaluation of all the core and the project. For the core story, so for the core, the administrative core, consortium core, methodology core, and dissemination core, so each of these core will receive 1 impact score. For the intervention project, we go back to the criteria of significance, investigator, innovation, approach, and environment, and each project will receive a score for each of the criteria and 1 impact score. There is additional review criteria. The criteria there are criteria that are included in a determination of the overall score. They do not get a separate score, but the reviewer take into account what these criteria are about. And very important, the human subject, the inclusion of women, minorities, and children, or vertebrate animal if they are involved, and biohazard. There are additional review considerations, and these criteria are not included in the determination of the overall score. They are discussed after the voting. So these criteria are the select agent research, the resource sharing plan, and budget and period of support. So during the review, some of the application may be streamlined, which means they are not going to be discussed. So for each application, an average of the preliminary overall impact score of the assigned reviewer will be calculated. The SRO will determine an average score cutoff point for discussion of the application. During the face-to-face meeting application, so during the face-to-face meeting, application with an average score under the cutoff point will be discussed, and the applications that are above the cutoff point, will be discussed only if a reviewer requested. So for the discussed application, assigned reviewer will summarize their prepared critique, and an open discussion will follow for the complete panel. The final scoring of overall impact score is conducted by private ballots. The final score is based on the average of all the voting reviewers multiplied by 10. So the score range goes from 10, which is exceptional, to 90, which is poor. A summary statement for the application discussed as well as non-discussed will be available approximately 30 days after the review meeting. One important thing is please do not contact the members of the review panel when the roster is available to you. This can bring a lot of problems. So please do not contact the member of the review panel, and do not let the reviewer to contact you either. If this happens, please contact someone at NIMHD. Thank you.
Thanks, Marion. Following initial peer review, recommended applications will receive a second level of review by the National Advisory Council on Minority Health and Health Disparities. The following will be considered in making funding decisions. First, scientific and technical merit of the proposed project as determined by the scientific peer review. Second, availability of the funds. Third, relevance of the proposed project to program priorities. And finally, geographic distribution of the award recipient. We have a list of selected frequent asked questions we have received, so I'm going to address some of them now. First question is, can we propose studies on chronic conditions not listed in the FOA? The answer is yes. Chronic disease conditions are defined here as conditions that last 1 year or more and require ongoing medical attention or limited activities of daily living or both. So this FOA, for the purpose of this FOA, chronic disease conditions that disproportionately affect health disparity population, including but not limited to diabetes, cancer, cardiovascular disease, kidney disease, HIV/AIDS, asthma, depression, and other mental illness, substance abuse, and addiction disorders. Proposed studies can include other chronic conditions not listed in the FOA as well. The second question, if there is an existing TCC in our region, can we still apply? The answer is yes. This is an open competition. And the third question, we already have a TCC or P50. Are we eligible for this FOA? The answer is also yes. Nothing in the FOA prohibits organizations that have an active TCC award or other awards from applying for this FOA. So all additional information of eligible institutions and applicants can be found in the FOA under Part 2, Section 3. Question 4. The FOA states that priority will be given to projects targeting communities without previous government-sponsored community-wide interventions. What does this mean? For this FOA, we encourage projects that move beyond the replication of previous prevention intervention research. For example, expansion of single-level interventions to encompass the expansion and scaling up of local interventions to address chronic disease prevention at the regional level. We expect that research expertise and experience learned from one community, for example, CBPR approaches, can be translated to another community. This does not exclude any previous or current federal-funded community health centers or other community-based organizations from applying. This also does not exclude any communities receiving government funding or programs to reduce health risk factors. However, priorities will be given to those applications targeting communities where no community-wide interventions research was or is being implemented. As a result, we encourage intervention research in resource-limited health disparity communities. However, the implementation of innovative or novel interventions in communities with previous prevention intervention will also be considered. Question 5, is there a definition of community-wide intervention? For the purpose of this FOA, we define community-wide intervention as research interventions at the community level, which will have an impact on the health of the majority of the population in the community. The sixth question, the FOA states that priority will be given to multilevel interventions that target 500 or more participants within the selected communities. Does that mean all interventions need to be recruit 500 participants? The answer is no. Proposed interventions do not need to recruit a minimum of 500 participants. We encourage multilevel interventions to engage or have the potential to impact at least 500 or more people within the community. However, we acknowledge that the research team may be in a better position to determine the sample size through power calculation for the interventions. Question 7, My collaborators and I have already completed many elements of the needs assessment to be conducted in the first year of the award. Can you clarify what is intended to be included in this first year comprehensive needs assessment? And also, biochemical measures expected to be included. We expect that investigators should already have a needs assessment and an intervention plan in the communities in which they want to implement multi-level interventions. The requirement for the first year comprehensive needs assessment is intended to give investigators additional time to synthesize and broaden needs assessments, including obtaining baseline data, for example, incidence data of chronic disease in the communities, and incorporating regional level data. This may also include adapting or tailoring measures, intervention elements, or data collection procedures to be more appropriate for targeted communities within the region. Most importantly, it will provide investigators additional time to enhance collaboration and build trust between not only their local community partners, but also other participants in the region. Biochemical measures are not required, but encouraged. Question number 8. The FOA states that in year 2 to 5, each TCC will initiate and implement multi-level interventions at individual, family, team, group, community, or higher levels, at least 3 or more levels, to improve chronic disease prevention and promote health equity. Does this mean that the interventions must be newly developed in the first year? The answer is no. The lack of multi-level interventions in chronic disease prevention means that some adaptation and modification may be needed in the first year. But we expect applications to come in with clear intervention plans for scaling up execution on a regional level. Question number 9. We have evidence of individual and community level interventions that have been effective in a couple of communities in which we are working, but would need to develop a third level intervention. Can we use the first year to plan and develop that third level intervention? The answer is no. All interventions must be proposed and justified within the application. Question number 10. Does the intervention pertain to selecting only one community as the intervention group? No. The intervention does not pertain to selecting only one community. Multiple communities can be included in the intervention. We welcome any innovative ideas, approaches, or methods. Question number 11. Is the community or communities to be selected on the basis of a single health risk factor that is high relative to other communities, or is the intent to select based on multiple health risk factors that a community exhibits compared to other communities? Studies focusing on multiple health risk factors are encouraged. If an applicant chooses to select a community or communities with a single health risk factor, a comparing argument, justification should be included. For example, highly prevalent, high morbidity, or mortality. This is a list of questions we have received. Now we will open the floor for any questions and answers. Please type in your questions so we can answer. We will read out the questions as we receive.
Hi, everyone. It would help if you could just click on Ask Questions here, and that way we'll send the questions directly to me, Joan Wasserman, and we'll funnel them through and get them answered. Any questions? Nothing? right, actually, we do have a few questions coming in. First question is, does the U54 need to address training and or pilot project cores?
No, there is no requirement for that.
Okay, the next question, is there a limit on how many partners we can include in the proposal?
No, there is no limit of partners. We encourage you to have as many partners for the from the community as possible.
Okay. Must we have a white reference group for our health disparities intervention?
In the FOA, we didn't have any specific requirement on this, so it's open to any innovative ideas you have or approaches you want to proceed.
Okay. Let's see. Just trying to get it there. Okay. Please clarify the statement under the research objectives that state, note, I'm sorry, we're jumping around. TCC awards, I'm sorry, I'll reread that again. Okay. Please clarify the statement under the research objectives that state, note, TCC awards will not support cores that duplicate interinstitutional resources or cores supported by other federal funding if those resources are already available for use by the TCC participants. If a P20 NIMHD-funded center has already funding for an administrative core, would that prevent them from participating in this U54, or can it be continued with the new funding once the P20 has expired?
All right, I'll try to take a stab at that. This is Mike Sayre. The purpose here is to avoid duplicating efforts and having, relatively scarce grant dollars being used to do the same thing twice. Now, with respect to an administrative core, so let's set aside the administrative core for the moment. Let's talk about technical cores. So if your institution, for example, has a biostatistics core or a bioinformatics core that's supported by some other grant, maybe it could be an NIMHD Center of Excellence grant or some other NIH grant. If the resources and the facilities and the expertise of that core is available to the TCC investigators, we're not interested in supporting a core that duplicates that service or those resources. Now, with respect to an administrative core, each center, because each TCC has a unique program, if you will, or mission. I mean, we have TCCs on health policy, TCCs on men's health. We would expect that each center would have a distinct administrative core that's designed specifically to facilitate the work of that center. That's not to say that people who are involved in administrative cores in other center grants can't be involved in TCC, in this particular TCC. But however you propose your administrative core, it's going to be important that you demonstrate to the reviewers that it's optimally designed and staffed to facilitate a successful completion of the stated aims for that particular TCC.
Thank you, Mike. Next question. Related to the point about just a single health risk factor, would proposing to focus only on smoking cessation be appropriate if high prevalence, high morbidity, or would you prefer a project on smoking and physical activity?
As we stated in one similar questions, we have no objection on just one single risk factors. So if you propose that and with good justification, the answer is yes, you can do that.
Great. And the next question is, can the interventions be different conditions? For example, diabetes in one community and hypertension in the other?
The answer is yes, you can do that.
Yes. Given that there are only going to be 2 to 3 grants funded and there is an overwhelming response, will they consider funding more than 3?
It's a question for Mike.
Well, it's impossible to predict. We don't have an actual a budget for fiscal year 2016, so it's depending on what our appropriation is, it's conceivable that additional awards could be considered, but it's impossible to know at this time.
Next question: Is it anticipated that a TCC region will include multiple states or just one state? That's part one of this question. So.
We answer the part one.
Oh yes, I'm sorry. Yes.
Or is there another part that's related to that part?
Can regions span parts of multiple regions?
Okay. Yes. So regions, the applicant, it's up to the applicant to define the region that you're going to be working in. We ask that you identify which of the HHS defined regions that you'll be working in. It could be one region, it could be 2 regions, it could be, you could hopscotch across the country and be involved in, communities on both coasts. Your regions can cut across state lines. It really depends on the population that you're involving in your projects. So it's up to the applicant to define the region. But again, as we say in the RFA, you need to provide a scientific rationale and a justification for why you're focusing on a particular region and the population. And it's important to note again the regional aspect of this. Many of our research project grants and some of our center grants, other center grants focus on, relatively small groups of folks, single neighborhoods or a single health care provider network. And we're really trying with the TCC program, not just this RFA, but all of the TCC RFAs to expand the scope of work to touch larger populations and have a bigger impact on a regional basis.
Thank you. Next question is it expected that projects will include multiple chronic diseases, for example, cancers and diabetes, or would you recommend focusing on one chronic disease?
We encourage to have multiple chronic conditions, but this is not a requirement.
Next, is a pilot award program beyond the 2 projects allowed or encouraged?
We don't anticipate to have pilot projects under this FOA. There will be 2 intervention projects, multi-level intervention projects.
This participant wants to know what NIMHD is thinking in terms of regional collaboration. Do we want actual projects co-led with other states within the region, or do they want cores to be co-led with other states within the region?
Well, again, it's up to the applicant to define the region. It doesn't your region doesn't necessarily have to include multiple states. It can be within one state. The point is that we're looking for interventions that target populations, larger populations, not just small neighborhood groups. But there is no requirement to have multiple states or any particular number of entities with any particular geographic distribution.
We might have addressed this already, but how are communities defined? If there are several islands, as in the Virgin Islands, could each island be considered a community?
That's a good question. In the FOA, we have a definition of the community we consider. In this case, my answer is yes. I mean, you can use one island as a community if you want.
Okay. The next question, concerning no previous community-wide intervention, is it okay if this effort focuses on different outcomes in the same community where a community-wide intervention already took place?
The answer is yes. However, as we mentioned in the FOA, priority will be given to those who has not have any community-wide interventions before. But we will consider all the applications as long as it's innovative and it can address the health disparity issues we concern.
The next question, is it 500 participants per intervention or for the 2 interventions?
The 500, again, is we expecting to have the impact on 500 more in the community, which is the purpose of the TCC, is to have a regional impact. We don't expect to tell you or to how many samples in that interventions you need to have. It's up to you to calculate the power analysis and to identify the necessary sample size you need.
I just want to give an example. So, for example, focusing on the impact on the population as opposed to enrolling a certain number of participants in an intervention trial. So you could imagine delivering an intervention to 5 county health departments, and that could have an impact on 50,000 people. So, I mean, when we talk about 500 or more, we're talking about the potential impact on a population, not necessarily not the number of people enrolled in a trial.
Thank you. Will the FAQs be available on the NIMHD website?
Yes, we will publish them. As long as this webinar, it will be published.
What do you mean by working with communities that don't have federal funding? Is this a strict requirement? Or if we have a sample size greater than 500, can it be a population that has federal funding?
Again, we don't expect to exclude any applications because they have previous community-wide interventions. But the priorities were certainly given to those with less research resources. Health disparity community will really need more research intervention, research resources.
And with this initiative, we're trying to expand the participation of health disparity populations in NIMHD-funded research. So that's one of the reasons why we're really interested in projects that reach out to communities that have not been involved in federally funded research programs or intervention programs.
Are P20s, P60s eligible to participate?
Yes, they are eligible.
I believe we touched on this, but I'll read it again. Will any preference be given to applicants that present projects across regions? We
don't have a preference for that. It's, again, as Mike mentioned, it's up to reviewers decide which application is more competitive or with merit.
Yeah, it's really going to be based on the science. So we don't have some arbitrary formula for the number of localities or jurisdictions. It's really going to be based on what you're trying to accomplish scientifically, and you have to make the case to the reviewers that what you're proposing makes sense.
Will there be an effort to distribute the awards across the U.S. versus funding 3 awards in one geographic area?
Geographic distribution of award recipients is one of the considerations that we will use for funding decisions. Not the only one, but it is one.
Is it appropriate to have an intervention that promoted the use of clinical prevention services as a primary prevention effort? So wanting to know.
In the FOA, we don't have intention to exclude any primary or secondary prevention measures. So as long as it belongs to the primary, secondary prevention, it's all eligible.
Is year one to develop the consortium, or should the members be named in the application?
Consortium partners should be named in the application. This is a little different from when we started the TCC program in 2012. We had a planning phase, a 1-year planning phase, followed by a 4-year implementation phase. That was driven in part by the relatively short amount of time that applicants were allowed to prepare their applications. In this case, we believe we're providing ample time for applicants to get organized. The consortium partners should be identified in the application, and there should be, credible evidence that they are actually on board, engaged, and that's why we ask for, signed letters of support that lay out what they're planning on, what their expectations are, and what they will do. And again, the interventions, as Dr. Zhang said, the interventions should be described in the application. So we expect these to be complete applications.
Yeah, as Mike mentioned, I just want to emphasize that the first year is really to give additional time for the applicant to build more trust or collaboration, and really to modify or adapt the interventions they designed. But the application actually need to include all the elements listed in the FOA.
Can we be part of more than one proposal?
Oh, yes. The application is really submitted by the institute. So you can be part of a co-PI on another application from another institute, but one institute can only submit one application.
With a multi-level intervention, can we use random assignment of levels within communities?
This is a good question. Really, we don't have any opinion on what innovative or novel approaches, method you can use. Just you can propose any approaches or methodologies you want to use. It's really based on the scientific merit. The peer reviewer will make the decisions and recommendations.
Will you kindly review the first-year needs assessment requirements? That was in the initial presentation. Could the person that submitted this question kindly let us know if you need us to address this again? We'll move on. If you do, just resend your text and we'll address it again. Okay, the next question. What is the relationship between a focus on community and a regional scale-up? So again, they're wanting to know what is the relationship between a focus on community and a regional scale-up. In
the FOA, we didn't have a requirement on how the community intervention will be having and how to have a regional scale up. It's really up to the investigators to design or to design your intervention actually.
Do the interventions need to be comprehensive?
I think these are really good questions for investigators to design and to think about to impress the peer reviewers. We don't have any requirement or any predetermined idea from this FOA. You can do whatever you think is appropriate.
Along those lines, should applicants focus on multiple health behaviors as well?
It's encouraged. As I've mentioned to one of the previous questions, if you only have one single risk factor you would like to address, as long as you have a good justification, it's also fine.
Will this TCC be reissued? Will the TCC U54 RFA be reissued, I guess, in 2016?
I think Mike has already addressed that question, so I'm not going to say anything anymore.
Will there be an effort to just, we saw this, what does multiple level intervention mean? Can you give an example?
A simple example is mentioned in FOA is at least for any designed multi-level intervention to prevent chronic disease, you need to have at least individual level, family group level, and the community level, which is already 3 levels. But you can also have a higher level intervention in the region area or in the state area. It's really up to the PI to decide what's the most appropriate multi-level interventions. The requirement is as long as you have at least 3 level intervention, that should do. The easiest, of course, is the 3 level I just mentioned, individual, group, and the community.
Going back to the needs assessment question, the question put forth is, if this is the needs assessment a requirement that happens after the U54 is awarded, how will the results from the needs assessment inform the center moving forward?
The comprehensive needs assessment, as we mentioned earlier, is really for you to have more deep collaboration or build trust, and also modify your intervention design. So we don't expect you to have major changes after the first year. So all the applications should already have a clear research design and a list of support and a strong collaboration with the community partners already.
Again, they are not sure about the response to the question about the U54 being reissued. Can you say yes or no?
Mike answered that question. I'm not going to ask him to do that again.
Well, I can't say yes and I can't say no. So I can say maybe. That's about all. It's going to depend on availability of funds and programmatic priorities. So it can't be. We can't commit one way or the other at this time.
Okay. Next question is, how will reviewers be instructed to compute the overall score? What weight is given to each core, et cetera?
The reviewer gives the weight to each criteria the weight they want. We don't tell them that one core is more important than another. It's them to decide. And it's just the final score is not the average of all the score that they gave, because some reviewers think that certain criteria are more important or certain core are more important. So, but it's their decision. We do not tell them what is the most important.
We've addressed all the current questions on the chat room. If you have any more, please type them in now. I'll give you a few minutes. Oh, okay, we have one more. If you have collaborators across one or more HHS regions, does that impact the review?
No, it won't impact the review.
Yeah, I think it's really the scientific merit. The proposal make the case. So it's up to the reviewers to decide which one is more, preferable.
Okay. Are there any plans to issue an RFA for P20 center grants if we choose not to apply for the U54?
Again, we're not in a position to indicate what we will or will not do in FY16. It's going to depend on availability of funds, and as I said earlier, we don't know what our budget's going to be in FY16, as well as the priorities of the Institute. And as you probably know, we have a new director coming on board next week. So there's going to be a lot of planning and discussions that goes on with regard to our planning for initiatives for FY17, FY16, and FY17.
Okay, does each intervention project need to be multi-level?
Yes. There need to be multi-level interventions.
Okay. Does the NIMHD partner need to be identified in advance of funding decisions? We don't understand what you mean by NIMHD partner. Could you rephrase your question? Okay, well.
You mean the program, the project scientist?
Oh, do you mean the project scientist? We just need you to clarify on who you are defining. Oh, the project scientist. No, those.
No.
No.
Yeah, you should not put any NIMHD names in your application. We will decide, after when awards are made, we will decide who the project scientists are and who the program officials will be for those particular awards.
Once you've received letters of intent, will applicants be able to inquire as to who within the geographical area has the intention to apply? No, the letters of intent are confidential.
Yes, they're confidential. They're just for the scientific review branch to understand how much work they're going to get and what the expertise are needed a little bit in advance.
Okay, that we're caught up on questions, so give you another minute or two to ask anyone have any other additional questions. give you 10 more seconds. If we don't see anything, we'll wind it down. And like we mentioned, there'll be frequently asked questions posted on the NIMHD website.
And where you'll find them on the NIMHD website is on the page that's titled NIMHD Funding Opportunities. So you can find a link to that on the home page. So look for the link to NIMHD Funding Opportunities, and that will take you to a page that lists all of the active funding opportunities, and then where there are technical assistance webinars for particular FOAs, you'll see links to the webinars as well. And the FAQs, when they're available, they will be posted along with the links to the webinar.
Okay, and will the slides be available independent of the webinar? So can they download the slides?
Yes, we can do that. Well, thank you very much for your interest in this FOA. Here is a list of contacts. If you have any question relevant to the FOA, please feel free to email me or call me. If you have any question related to review, please contact Marion. And if you have any question related to grants, also you can contact Priscilla Grant. Thank you very much. Have a good day.